morning and welcome to today's general surgery grand rounds. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. Please fill that out. If you are board certified through the American Board of Surgery, you will need to fill the evaluation out to give us permission to report your credits to the Board of Surgery. It is my pleasure to introduce Dr. Nelson Royall. He is a Hepato-Pancreato-Biliary surgeon within the Department of Surgery at Northeast Georgia Medical Center. He is the Cancer Liaison Physician for the Cancer Committee and an Associate Program Director for the General Surgery Residency Program at Northeast Georgia Medical Center. He is the site investigator for multiple national clinical trials at Northeast Georgia Medical Center, as well as the principal investigator on research studies across pancreas, liver, biliary, and neuroendocrine diseases. He is also a specific clinical interest in robotic surgery, advanced endoscopy, and complex diseases such as neuroendocrine tumors, polyposis syndromes, and pancreatitis. Join me in welcoming Dr. Royall.
Thanks, Jennifer. Thanks, everyone, for the opportunity to give this talk today. So we'll kind of jump past the disclosures and start talking about the basis for how this topic that we're going to get into came about. So colorectal cancers as a whole are the fourth most common cancer in the United States. They're the second most common cause of cancer death in the United States, representing about 53,000 deaths per year. The median age that someone's diagnosed with colon cancers is about 66 years. It used to be 72, and that continues to become a younger disease, unfortunately. The risk is obviously significantly increasing in our under 50 population, so representing now more than 10% of the new colorectal cancers, although the risk for over 65 is decreasing, likely due to surveillance. The 5-year overall survival, all comers, is 64%, and those with metastatic disease, it's only about 14% 5-year survival. And interestingly, among people with metastatic disease, having age under 50 is going to be a worse prognosis. So about 50-60% of people with colorectal cancers will eventually develop metastatic disease, the liver being the most common of those sites. 40-50% of all patients will develop colorectal liver metastases. Isolated liver metastases represent about 20-34%. Of those patients with colorectal liver metastases, metachronous metastases will occur in about 15% at 5 years for all patients. And of those, 80-90% will be unfortunately unresectable at diagnosis. Separately, peritoneal metastases will occur in about 17% of patients, and it'll be isolated peritoneal disease in 2%. Whereas pulmonary metastases occur in about 4-5% of patients with both liver and lung synchronously. So if you're looking at where the metastatic disease burden tends to be, it tends to be heavily focused on the liver. And we'll talk about that in just a minute. So colorectal liver metastases are actually the main driver for overall survival in these patients with metastatic colorectal cancers. 30% of patients will have liver-only metastases at death. Those with resectable liver metastases have a 14 to 21 month median survival without any therapy. Those with unresectable liver metastases at diagnosis without any therapy have a 4 to 12 month median overall survival. Even though you may have a terminal diagnosis with liver metastases in colorectal cancer, it doesn't mean that you have less than a 1-year survival. We're still talking about almost a year and a half to 2 years on average for patients with resectable disease. Obviously worse for unresectable disease at diagnosis. And of these patients, about 50% will have extrahepatic disease. So let's talk about colorectal liver metastases. Historical therapies that we've had are going to be surgery and other kind of local therapies and resection. For synchronous metastases, if we're able to do a complete resection of liver-only metastases, you have about a 50% 5-year overall survival. That's obviously a lot better than what we talked about a minute ago, and it's improved when we can combine the best option is going to be when we combine the primary tumor resection at the same time as the liver metastases resections. For patients with liver and lung metastases, we've actually shown an improved overall survival if we can do a complete cytoreduction, and we'll get those patients about 31 to 57% 5-year overall survival. And this is based on data out of Sloan Kettering and MD Anderson. For patients with liver and lung metastases who undergo liver-only therapies, that means we're leaving the lung metastases intact, they actually have a 13% 5-year overall survival, which is better than obviously chemotherapy alone, which is only 1 to 2%. So it's interesting, and that's kind of further supporting the idea that colorectal liver metastases are the site of biology driving for these patients' survival, not their lung disease. And there's some hypotheses about why that is as far as enzymatic production in each site with 5-FU-based drugs that are traditionally the systemic therapies for colorectal liver metastases, but nothing's been definitively proven. Similarly, for metachronous metastases, these patients are obviously going to have a better overall survival than their synchronous metastases cohort, and they'll have about a 60% 5-year survival with complete liver-only disease resection, as compared to a 31% for patients with liver and lung cytoreduction. Interestingly, even though everything else has kind of shifted for the most part between synchronous and metachronous, for patients with lung metastases, their survival tends to mirror the patients regardless of timing of the metastases onset. That gets us into timing of systemic therapy. Obviously, we know this is a systemic disease at the time when they have liver metastases. And so our question is going to be, should they get systemic therapy? And if so, how do you time it out to their liver-directed therapy? And so, interestingly, 50 to 70% of patients overall will have a recurrence after you undergo liver cytoreduction completely. 50% of those recurrences will be within the liver itself, and 50% will be outside the liver. Overall, 5-year survival is about 30% if they do develop a recurrence. And so that's really the problem that we're looking at, is how do we reduce this recurrence risk for these patients after they undergo liver cytoreduction. There have been 2 large randomized controlled trials done, actually one that was basically 2 separate arms. EPOC, which was done in Europe in 2008 and subsequently re-reported on 2013, compared the benefit of perioperative FOLFOX6 regimen for patients undergoing resectable liver disease, whether that was metachronous or synchronous, and it was pretty well broken down. It showed that for patients undergoing no systemic therapy, they had a 51% 5-year overall survival, and for patients undergoing systemic therapy, it was 47% 5-year overall survival. So slightly trending in the worst direction for chemotherapy, and that's pretty much in line with the rate of drug-related adverse events for the systemic therapy cohort. There was no improvement in oncologic outcomes, local recurrence, disease-free survival, only a higher rate of drug-related toxicity. And so based on that trial, that really started a lot of questions about what are we doing with systemic therapies in these patients with resectable liver-only metastases. Separately, in Japan, they did the JCOG 0603 trial in 2021 that showed a similar result of patients undergoing resectable liver metastases, whether synchronous or metachronous, undergoing adjuvant FOLFOX. And in that patient population, similarly, they saw a 3-year overall survival of 86% for no chemotherapy and 91% for those with chemotherapy. Again, no significant difference, and again, the only difference being a higher rate of adverse drug-related events in patients undergoing systemic therapy. So based on this, really
Do you know if there's intention in that second study?
Yes, these were intention to treat studies.
To see what the 5-year numbers are?
In the JCOG trial?
Right.
They are following it for 5-year data. This was just last reported in 21, and they'll be reporting likely in... Yes. And these numbers are aligned with what we would see in 3-year survival in the EPOC study as well. So the short answer is really neoadjuvant systemic therapy, adjuvant systemic therapy really haven't shown overall survival benefit for patients with resectable liver-only disease. It increases perioperative complications. with a higher rate of hepatic insufficiency and hepatic decompensation postoperatively. And similarly, the EPOC study included neoadjuvant cetuximab regimens for patients and showed a slightly improved survival for patients with KRAS mutants. So outside of that subset population, we really haven't seen systemic therapies be beneficial to the resectable population. That is not reflected in our current guidelines, or I would say in most Western practices right now, because obviously we understand that these are systemic diseases. But if you take all comers with resectable liver-only metastases, we have not shown benefit. We probably need to do a better job of parsing out which patients are going to benefit from the systemic therapy versus which can be excluded. Moving on to unresectable colorectal liver metastases, these are obviously patients that we can't do surgery, we can't do ablations or other therapies for. Systemic therapy with first-line FOLFOX or FOLFIRI really hasn't shown a significant conversion rate in that trial. In the CELUM randomized controlled trial back in 2010 that included cetuximab for FOLFIRI patients or FOLFOX patients, they saw a 30 to 38% conversion rate to resectable. And in those patients that were converted to resectable, they averaged about 8 cycles of neoadjuvant systemic therapy. Obviously, oxaliplatin and irinotecan are not ideal for the liver, so we would expect a higher perioperative morbidity, which they witnessed in their trial, of about 36%. Of patients who did convert to resectable, they had an improved median overall survival of about 30 to 36 months. Specific to the KRAS and BRAF mutants, we know that those mutants are associated with significantly worse prognosis, particularly BRAF mutants, and we've shown that there's an improved response rate in those patients with wild type for FOLFOX only regimens, whereas the addition of bevacizumab in the FOLFOX regimen also similarly improves response rates for the RAS mutant population based on a trial out of 2020. Second-line systemic therapy, unfortunately, is not very effective. We only see about a 4 to 6% response rate if they fail first-line therapy in unresectable colorectal liver metastases. So that's kind of the scope of the problem. Obviously, there's a majority of patients that we're not going to be able to help with systemic therapy alone. And so that's where the interest in hepatic artery infusion came about in the 1960s. The idea being that you could avoid the first-pass drug effect and use that to your benefit and give a higher dose of local therapy to the liver, specifically where the disease is. So the rationale for hepatic arterial infusion rather than portal vein infusion is that most liver metastases, particularly colorectal liver metastases, are arterially derived for their perfusion rather than portal venous perfusion, whereas the normal hepatic parenchyma is predominantly perfused by the portal venous system. And so that would allow you to give higher arterial dose of medications than before seeing background toxicities. So the first studies were done in the 1970s, really, that were reported on that showed that percutaneous hepatic artery infusion was effective but had significant difficulty due to the requirement of multiple percutaneous access, and they saw increased toxicity because of the bolus-based dosing that it required. You could not continuously infuse a drug. And so in the 1980s, a hepatic artery infusion pump was developed that cannulates the gastroduodenal artery and allows a continuous infusion rather than a bolus infusion. And the initial trials were unfortunately limited due to some technical challenges with the cannulation, as well as systemic toxicities that within the biliary system that were not recognized at the time. Overall, hepatic artery infusion drug therapies that have been investigated to date mostly focus on 5-FU-based metabolites, and the reason is that their half-life is short and their hepatic clearance is high, and that makes it a good candidate for hepatic artery infusion. When you have a high systemic exposure, that's also not an ideal. So 5-FU-based drugs undergo hepatic metabolism, and so you're not going to get a lot of systemic absorption once you give it to the hepatic artery. Things like mitomycin C, cisplatin, and doxorubicin have high passage through the liver into systemic therapy, which is not ideal when you have hepatic-only disease. So overall, the goal with hepatic artery infusion is to take unresectable colorectal liver metastases and convert or downstage them to resectable so that we can put them into that better overall survival population, at a minimum to improve overall survival and provide some level of palliation from their hepatic disease, preventing hepatic decompensation with prolonged platinum-based therapies. For resectable colorectal patients, we're trying to reduce their local recurrence or even their systemic recurrence from that 50 to 70%. And so the goal would be to treat the micrometastases that are likely the source of that recurrence. And so that's the basis for hepatic artery infusion. So hepatic artery infusion can be combined with systemic therapy. The hypothetical points of placement would be to place the pump at the time that you do your definitive liver cytoreduction in a resectable patient, with the idea being that hepatic artery infusion pump will improve the median overall survival, and hepatic artery infusion will improve the hepatic-free survival. And so there's been several studies that have been done since the development of the hepatic artery pump in the 1980s, focused mostly out of Sloan Kettering through Nancy Kameny, who is really the pioneer in hepatic artery infusion for colorectal liver disease. She first reported on in 1999 about 156 patients comparing hepatic artery infusion with systemic therapy versus systemic therapy alone, FOLFOX being the predominant regimen within their treatment, and they showed that the 5-year overall survival was improved with hepatic artery plus systemic versus systemic alone. She subsequently performed led an ECOG trial that reported in 2002, showing similar overall survival benefits for hepatic artery infusion plus systemic therapy alone. And then subsequently, there's a trial out of Greece that reported similar types of results. And so the takeaway for this is for resectable colorectal liver metastases, in patients where you're going to be high risk for local regional recurrence, meaning more than one. Traditionally, we would use the Fong score to look at bilaterality, size of metastases, timing of metastases, but none of these trials actually required any of the high-risk classification based on their protocols at Sloan Kettering at the time. You can identify a patient population likely that resectable liver metastases would be a benefit to have a hepatic artery infusion pump placed at the time and given adjuvantly. For the unresectable patient population, it certainly makes more sense since we have only about a 30 to 36% conversion rate to resectable. And so placement of hepatic artery infusion pump at the time of systemic therapy initiation and given concurrently improves the conversion rate between 42 to 47% of the time will convert them to resectable. And in those patients that do convert to resectable, we see a 5-year overall survival rate of 63%. So even better for patients that underwent systemic therapy alone and converted, which is interesting and suggesting that the treatment of micrometastases is relevant to these patients. In patients that do not convert to resectable, they also see a similar benefit in 5-year overall survival of about 12.5%, which is significantly longer than the 1-2% that we would see with systemic therapy alone. It has been looked at comparing hepatic artery infusion therapy to Y90 radioembolizations. Hepatic artery infusion pumps provide about a 31-month median overall survival in retrospective series compared to 16 months with Y90 radioembolization alone. That's based on a trial, or that's based on retrospective data. Similarly, UPMC reported on the cost of care difference between hepatic artery infusion pumps versus Y90 radioembolizations for these patients and saw about a $16,000 per patient cost reduction with hepatic artery infusion versus Y90 radioembolizations. All right, so I'm going to hop along and we're going to talk about the kind of mechanics of hepatic artery infusion therapy selection and then how we do it. In hepatic artery infusion, the principles still apply for all other cancer care. They need to have a performance status between 0 to 2 on the ECOG scale. They need to have baseline liver function testing. We routinely check MRI liver protocols on these patients, not just to understand the baseline burden of disease, but also to understand the disease, the arterial anatomy, and that can be used for planning. Because this is an arterial-directed therapy, patients do occasionally have replaced or anomalous arterial supply not from the gastroduodenal artery. We would have to address that at the time to make sure that those areas where liver disease is being perfused by the hepatic artery pump. Other considerations that we would have that are general contraindications to hepatic artery infusion pumps is the presence of peritoneal metastases, bone metastases, or more than 70% hepatic replacement by tumor. And that's just because of the likely association with portal hypertension from tumor replacement. Generally, patients with portal hypertension are going to be contraindicated to undergo hepatic artery infusion pumps due to the higher biliary toxicity due to the FUDR regimen. Portal vein thrombosis similarly, bilirubin over 1.5, high ECOG performance status, and social limitations, and that's simply due to the requirement to come in for infusions. So nothing unique to what we would consider typical contraindications to hepatic artery therapies in the first place. So the actual nuts and bolts of undergoing hepatic artery pump is, historically it's been done through a laparotomy, although nowadays we perform them minimally invasive, typically robotically. We identify the gastroduodenal artery, and we do have to ligate the gastroduodenal artery. That involves the same risks as any other procedure where we're ligating or occluding the gastroduodenal artery. We have to check for patency of the superior mesenteric artery as well as the celiac artery, and may require interventions to resolve any stenosis that we find preoperatively. And then we ligate the right gastric artery due to common origin from the gastroduodenal or malperfusion to the liver. And we make sure that we ensure only arterial supply to the liver is coming from the gastroduodenal artery-fed branches. If there's a replaced right hepatic artery, that may involve either ligation of that artery or reimplantation into the standard arterial system. We create a pocket in typically the left side of the abdominal wall for about a hockey puck-sized pump, and then we introduce the catheter into the gastroduodenal artery, and we flush it with methylene blue to make sure that the liver is the only area being perfused by the pump. We don't want duodenal, gallbladder, stomach perfusion that can sometimes occur. If we see malperfusion, we address that at the time of the resection or at the time of the placement, so that at the end of the case, there's only liver perfusion. Occasionally, we'll have areas of the liver that are supplied by aberrant diaphragmatic arteries, and we would ligate and address those at the time. So again, the only perfusion arterially to the liver is coming from the GDA branches. And then we heparinize the pump, and the patient is sent home typically the same day. Like I mentioned, the gallbladder we do address at the same time. Most of the time, we're removing the gallbladder to prevent any gallbladder perfusion of the FUDR, which would be toxic. Post-operatively, in the outpatient setting, we do a SPECT scan to again confirm perfusion of the liver to the by the GDA, by the hepatic artery pump, as well as to rule out extrahepatic perfusion, and to calculate a lung shunt fraction. The lung shunt is a risk that the drugs are being shunted through the liver into the systemic, and we want a shunt fraction less than 20%. Typically, we don't see that. There are certain tumor types that do have more arterial venous shunts to the hepatic system that can cause higher shunts. Some hepatocellular carcinomas do that, although we're not typically doing that for HCC tumors currently. Some of the larger cholangiocarcinomas that get hepatic artery pumps can have a higher shunt fraction. And then we'll do embolizations if needed, and that can actually be used for high shunt fraction patients to improve the shunt fraction to where they would not have as much systemic exposure. And so this is what the pump looks like. This is the mechanism. The important part is the needle stop and then the reservoir to contain the drug therapy. The cycle of infusion is typically over 14 days for FUDR. They're getting dexamethasone similarly with it. And then a heparin infusion to keep patency. And then after 14 days of slow perfusion, they come back to the clinic and they get it flushed with heparinized saline. For patients that are off hepatic artery perfusion, they get an every 6-week maintenance injection with glycerol to slowly keep the pump from clogging. The pump, typically we don't remove it in these patients unless they're someone with very low risk for recurrence. It's very easy to get your pump flushed with glycerol every 6 weeks. and typically not particularly painful. And so probably this is the biggest advance that Dr. Kameni really pushed during her career, was working on the complications that we encounter. The technical complications as the proceduralists that are placing these is really something that we control. Pump-related things like seromas, hematomas, surgical site infections, malpositioning, we don't see very often. If we see an issue, we typically just manage it conservatively if it's like a seroma or a hematoma. Surgical site infections obviously could lead to pump explantation, which would be bad. And so standard precautions are used against that. Catheter-related complications, reportedly about 6%. This was more towards the 1990s data before some of the advances with pump lining to prevent occlusions. But when they do occur, if we get an occlusion, we do TPA just like you would a normal Metaport for the venous system. Malpositioning, typically the issue can be addressed by either embolization or stents, or rarely a revision is needed. Erosion is extremely rare, but typically we would see a pseudoaneurysm in the arterial system, and that would be managed with a covered stent or an embolization depending on the location and size. Drug-related toxicities is really the bane of the existence of this system and what drove a lot of people away from it initially in the 90s. Vascular toxicities historically occurred due to probably the bolus dosing and issues with the pump initially. And so there's been improvements in the drug dosing regimen. The biliary complications, really the dexamethasone has helped with that over the years to reduce the risk of biliary complications. But this goes back to, I think, experience with the perfusion and the therapy that is really why the system, as it's been rolled out to most other centers in the United States, has had a mentorship model for the clinics to make sure that they're recognizing biliary complications and avoiding it. We do avoid anti-angiogenic agents in these patients who have a hepatic artery infusion pump based on the lack of improved response or survival data that was done in Sloan Kettering initially for these patients, but also because that reduces the risk of biliary complications. And this is just kind of an overall algorithm that's used for the FUDR hepatic artery infusion therapy. So currently there are several trials in the United States that are looking at, and as well as the US, that are looking at applications of hepatic artery infusion therapy. I would say nowadays it's pretty well accepted that hepatic artery infusion therapy for unresectable or high-risk resectable colorectal mets is going to be associated with improved survival. It's more access to different communities. If you live in a large urban center, if you look at the map, most large urban centers like Atlanta or North Carolina or Nashville have hepatic artery infusion therapies at least one center. So you're not asking people to drive hours away. For a center like Gainesville, it's a little bit farther to ask them to drive into Atlanta or whatnot. And so really the questions that we're trying to figure out is, really we're still asking the same question about systemic therapy. Since we know that systemic therapy alone has not really led to significantly improved survival, we're trying to address, are there patients that we can omit the systemic therapy regimen for? And so this trial out of the Netherlands is looking at low-risk patients for resectable-only disease, omitting systemic therapy. And then there's a French trial that's looking at adding oxaliplatin instead of FUDR. There's a trial out of Norway that's looking at liver transplant in comparison to hepatic artery therapy. That's a therapy that is not widely available in the United States, so probably not quite pertinent to our patient population. And then there's, in the United States, there's interest in using hepatic artery infusion therapy for unresectable cholangiocarcinoma, where there's been early data suggesting improved survival, and that trial is ongoing. So lastly, some considerations that we have for unresectable intrahepatic cholangiocarcinoma, since I skipped over that. The incidence of cholangiocarcinoma as a whole is about 2,400 cases a year. That's relatively a small number. The incidence is increasing progressively. We don't have an idea for why that is. The median age diagnosis is about 70 years old. At presentation, resectable patients will have a 20 to 30 month overall survival, but a 60% risk for recurrence. And unresectable patients will have a median survival of 5 months. For unresectable disease, obviously, there's no local regional therapy. There's questions about Y90 radioembolization in combination with systemic therapy, but systemic therapy alone is the standard of care currently. Gemcitabine cisplatin has been associated with an 11 months median overall survival based off the ABC02 trial. Gem-Ox has been associated with between a 7 to 15 month overall survival, and then Gem alone is about 8 months. And then we have 5-FU cisplatin and 5-FU alone, which are similarly not significant improvements in overall survival. So if we looked at the Y90 plus systemic therapy combination, they saw about a 22-month survival, although this data was retrospective and obviously highly selected to patients that were candidates for Y90s. So obviously there's a potential role for hepatic artery infusion for unresectable intrahepatic cholangiocarcinoma. And so that's really where the interest has come in the United States because of our increasing patient population. Hepatic artery infusion improves biliary chemotherapy delivery since the biliary system is perfused exclusively by the hepatic arterial system. And so the centers that have explored hepatic artery infusion for intrahepatic cholangiocarcinoma have used exclusively FUDR plus systemic GEMOX. And so far, they're seeing 5-year overall survival rates of about 9.7% and a median survival of about 25 to 29 months. That includes about a 10 to 20% conversion to resectability. These are pretty dramatic responses that have been seen in these patient populations, and we'll see further with the NCI trial that will be reported on hopefully in the next couple of years if it's held up in randomized fashion. And so these are the 2 trials that are looking at HIA currently for intrahepatic cholangiocarcinoma. And with that, I'm going to wrap it up and leave time for any questions that people have.
Oh, I was just going to ask, are we doing any of these trials here?
No, we currently are working with the medical oncologist to try to develop a hepatic artery program.
So how you described here, the conversion resectability about 10 to 20%, does that change that overall 5-year median survival if you get to the point where you are able to resect?
Oh, if you're resected, yes. Your median overall survival, I forgot the exact numbers, but it's dramatically higher than the 25 to 29. It's just when you're only getting 10%, it's hard to tell someone that you're going to be in that group.
Thank you for the talk. I apologize, I missed a lot of it. Would you comment a little bit about, it's a great tool and it's used widely at big tertiary care centers, referral programs, not particularly in community institutions. Any comments on the penetration of its use in the community, and if you could also comment on the financial feasibility for such an institution? I would love that. Thank you.
So going back to its development from the 1980s until probably about a few years back before COVID, you didn't really see sites outside of Sloan Kettering or even, mostly it was Sloan Kettering in the United States looking at hepatic artery infusion therapy, and that was Nancy Kameny, who was a medical oncologist who strongly believed in the therapy and had an exclusive practice to colorectal liver metastases or colorectal cancers. And she really pioneered the work on figuring out how to dose it safely, and how to align it with existing systemic therapies. And she did this in the era in the 90s, really where we were changing the systemic therapy regimens for colorectal cancers. And so there really wasn't much interest in that until she figured this out with the randomized controlled trials in the early 2010s that started reporting on. And at that point, you started seeing graduates from Sloan Kettering's fellowships go out to the community, and because of the dramatic response rates and survival differences, they had an interest in bringing it online. And at the time, Johnson & Johnson was the only manufacturer of the pump, and that led to challenges in delivery of the pump to new centers, and so it was a little bit slow to take up. And then right before COVID hit, Johnson & Johnson stopped manufacturing it because they didn't see it as a viable financial option for them. And it was about 3 years ago that a different company bought the patents as well as the manufacturing and brought it back online. Sadly, that was around the time, again, that people had a growing interest in it, and you saw more sites trying to come online, like Cleveland Clinic, Emory, Duke, and whatnot, and they began adding data to the patients showing that, yes, this is effective outside of a single center in New York City. And so now, recently, we've had a massive expansion across urban centers that have access to this, predominantly in places that had trainees from New York at some point. You're starting to see people that have trained outside of New York adopting it because, again, the data is being proliferated through conferences, and there's more regional support, mentorship for people that are starting these programs. But that's been the barrier, is having someone that has any level of experience. Dr. Kameni was fantastic in helping new sites come online as far as providing on-site mentorship and tele support. She's recently retired, but she has kind of created a network of people, medical oncology side, to support new medical oncology programs wanting to do this. I would say from a surgical standpoint, it's not really a technical challenge other than you just need to learn how to place a pump into the gastroduodenal artery, which is a standard thing for hepatobiliary surgeons. Really, for a site to do this, I think you need to have both hepatobiliary surgery as well as GI medical oncology practice to see enough of these patients to where you're not doing 1 or 2 of these a year, you're doing, you know, at least a dozen or more of these per year. Because again, the complications aren't common like they were when it first developed. They're relatively rare. And the devices are not, I would say, overwhelming from a cost standpoint for either the patient or the system, although there are certainly upfront costs for placing a device that only one manufacturer makes. But when you compare that to the survival benefit as well as the reduction in costs of care elsewhere in patients that are going to die of colorectal metastases, there's a significant system as well as just overall benefit to the patients in performing these. So the financial aspect is obviously, you know, that's hard to handle at first, but it's not anywhere near the cost of other therapies that we have, like surgery or whatnot. Selfishly, since we're now bringing online the histotripsy program here, there's been a lot of interest in the hepatic artery infusion pump community. The addition of histotripsy to hepatic artery infusion therapy to improve the conversion rate for unresectable liver metastases patients to try to get that higher than the 60% that we're at currently with HIA alone.
More presence of champions for the procedure and the support around it that would guide whether or not you can start it at a community institution.
Right, and I think people, you know, new is always challenging, new is always scary to some extent, and so you have a fear of the unknown. Johnson & Johnson probably didn't do a great job of providing local support to clinics. They kind of just provided the pump and the access supplies. The new company that makes it has done a much better job of providing local support to clinics that are starting programs and making sure that as they get new office staff or infusion staff that they feel comfortable with accessing it safely. Because again, the number of sites across the U.S. has just exploded in the past 5-10 years. We're no longer talking about this as a, you know, NCI-only research initiative. This is now diffusing to community centers, and you're seeing it at more large community centers that are doing this. It doesn't just live within academic centers.
This is probably a silly question, but I have an electric car and I have to plug it in every night. How does this pump powered?
So it's a mechanically driven perfusion that leaches. So going back to this, there is basically resistance created under pressure through this flow resistor so that it can only perfuse out at a certain rate. That's why glycerol is the infusion to give to someone that we fill it with when they're not undergoing any hepatic artery infusion, because glycerol is so thick that it creates a higher pressure and it's a slower leach, but it's slow enough to prevent obstruction of the catheter.
When it was just Dr. Cabini in Sloan in New York, Ken Dixon put liver pumps in 2 people with liver-only disease. So my job was to give the chemotherapy and put the stuff in the pump and not put it somewhere else. So the most important thing from my point of view, technically, was to put the needle into the pump when I wanted to empty it and not put any pressure on the syringe to let the pump the contents out. Then I had the needle anchored in my hand and I didn't move that the whole time. So someone else had to take off the syringe and put on the new syringe, and they might have even had to pump it. By doing that, I was pretty sure that I was putting the fluid into the pump and not into the pump pocket. The second patient Ken sent me, after a while his liver disease progressed and he needed pain medicine. He'd had some trouble with narcotics in the past, so he didn't want systemic narcotics. So I said, I can put morphine in this pump, which I did, and it worked great. When the hospice had to fill his pump, they forgot the rule of don't let the pump empty itself, don't help it. So they put their whole dose, 2-week dose of morphine into the pump pocket. And it wasn't too long, like probably the same day, that the patient's wife called up, and he was obviously in trouble. So Alan and I went somewhere up the Sati-Nakuchi Valley with all the Narcan they had at Lanier Park Hospital, and sucked everything out, aspirated that we could, and then gave him a lot of Narcan. So he survived this incident, but he didn't want any morphine in his pump.
His respiratory rate was 4 when we were there in the house.
So from the technical point of view, filling and non-filling the pump, the most important thing is let the pump empty itself and be sure that the needle can't move from between the time the pump is emptying itself and when you are filling the pump. Because, it was pretty neat. These people they were never close to resectable. They had a whole lot of disease. And they did get better for a while. And the toxicity was okay. They felt good. They could do what they wanted to do. They weren't taking pills. So, with Dr. Royall's expertise, this can be done here.
I agree. So, and that the 90s era was challenging. When you look at resectability rates, they've gone up since the 90s. The therapies and the approaches that we have, staged approaches, embolizations for hypertrophy.
Well, you're able to do you're doing liver resections. Liver resections really, we weren't trying to do any liver resections here. And I sent some patients to Dr. Staley, but it wasn't anywhere close to everybody with some liver disease that I send to Dr. Staley. So the toxicity, you've gotten a lot better.
Right. So I think, when we look at conversion resectability, we're seeing higher rates than the old reported data that Dr. Kameni had initially in 2010 and 2011, simply because surgical techniques have gotten better. At institutions like Sloan Kettering that have been doing this for a long time, their rates are much higher for resectability. Not having the toxicities in the biliary or arterial systems that they had in the early era of placement of these back in the 80s and 90s also helps a lot, because you're more comfortable putting in these people who will benefit from it, like the high-risk resectable population. So definitely it's I think, again, going back to Dr. Jackson's question, why has it historically lived in academic centers? It's the fear of how to access it and what to do with it. And now that more oncologists coming out have used it in their training, they want it to continue to use, because they don't want these patients, sitting with unresectable disease on systemic therapy for 20 months and getting systemic therapy adverse events.
Thank you.
Thank you all for coming.